Hello everyone and welcome to this webinar on Incathlab, and today we're going to talk about lithotripsy, and it's a very exciting time because the new randomized control trial data of the Disrupt PAD 3 trial came out, and today is my pleasure to present the speakers of this webinar. Well, Professor Zeller from Bad Kreuznach is Professor Gunnar Tepe from Rosenheim and Dr. Arne Schwind from Münster. So today is going to be a quite busy afternoon. We will go through some data, of course, as I said, but also through some cases to make everything more interesting and to go more deep in our daily practice, because we all face the same difficulties, and Shockwave today is going to show us how we can overcome some of the problems that we can encounter in our everyday life in the lab. So let me start then with the poll to start with. So can I have the poll? So, but the poll is how many participants have used IVL? And so, and then also there's a question together with it, which is like, if you haven't used IVL, for which reason? And I would like you all to be able to respond to the question. So answer A, do you currently use IVL in your regular practice? Answer B, no. Yes or no? I think we can maybe close the poll and launch the second one. Okay, so if you use it, why don't you use it? Okay. So essentially, I will just talk about what, when, where, and why we need intravascular lithotripsy. So, and the question is open, but we all know that endovascular treatment for calcified PAD can be a challenge because calcium restricts arterial compliance, and we all know that. And this can result in poor balloon expansion, dissections, and perforation. This is something that no one wants to see on the screen, of course, when we operate. And also, the calcium may impair effectiveness of DCB by limiting drug uptake. So, there's always the bailout of stenting, but stenting is not that, there are some complications which can happen with the stent, especially in the long term, and may complicate future revascularization attempts. So, and in doing this procedure, also other devices can be used against calcium, but there are some risks again, like distal embolization, dissection, perforation, which can remain as a concern with atherectomy treatment. And the patient also with moderate severe calcification are often excluded from endovascular treatment trials. So there's a little evidence to provide treatment guidance in these kind of very challenging patients. And this is why I'm so excited today to present this webinar with this expert about the treatment of calcified lesions. So, because essentially when you have very high level and dense calcification, you can encounter dissection when you do angioplasty, you can encounter perforation for need then for cover stents, you can get embolizations either for angioplasty or either when you perform atherectomy. You can have as a last image a vessel recoil, or even worse, a stent crush. So all this together with as we said, the limited drug uptake. This is a picture from the famous paper from Fanelli, where of course the drug is stopped by the calcium and can't reach the media. And also the problem could be at the level when you want to do any other procedure, especially in the aorta, iliac access could be a problem because the very calcified access can limit our options. So essentially, just to briefly talk about intravascular lithotripsy for whoever is not very used to it, is of course localized lithotripsy to treat the localized calcium. It comes from the experience from urology colleagues. So it's something not new, 30 years of data with very good safety and very spread use of it. And of course the waves generated by this kind of machine just disrupt the calcium but leave all the other tissues safe and healthy. This same concept was taken in the cardiovascular field, and actually we have now catheters for both the coronary and the peripheral system. Essentially how it works, the intravascular lithotripsy is a balloon essentially, and on the balloon there are some electrodes, and they create 1 pulse a second of signal, which create actually, despite the balloon is a very low in pressure, roughly 2 to 6 atmosphere maximum, the pressure that we obtain at the level of the vessel which we treat is roughly 50 atmospheres. So despite it's very gently inflated, it's very aggressive against this calcium. So essentially we deliver the catheter, which like as a normal balloon, we inflate to low pressure, and then we push just a button, which is extremely easy to be done, technically speaking. It generates sonic pressure waves, and of course it acts against the calcium. So it cracks it, and at the end of it, it safely expands the vessel. Of course, you know, this is the main picture, I think, of my presentation is the treatment of a cadaver specimen before and after lithotripsy. So you can see it's very easy to see the calcium on the surface of the vessel, and post IVL treatment, you can see all the cracks. So essentially, of course, you know, you have in real life a case like this with a very calcified lesion, and you can see the calcium even on this screen. And the calcified lesion is treated with this low pressure IVL balloon. And after IVL, you can see how the vessel looks completely different, not only because it's open, but also because there's no anymore this kind of constriction made by the calcium, which is the main target of our procedure. So the final, after normal angioplasty, after POBA or after DCB could be the same thing, you know, then it just serves to stabilize the result which we obtain with the IVL. So IVL treatment at low balloon pressure, in this case, and like in many other that probably our experts will show us today, result in marked improvement in diameter stenosis with no stent implantation. So which kind of type of calcium then can be treated with the IVL? So any, eccentric or concentric. Treatment strategy can work as a standalone, of course, then with, as we said before, with some sort of angioplasty with POBA or DCB after. So also as a vessel preparation, even for stents. So when, you know, want to put a stent, we can't achieve the right diameter of the vessel. And of course, it works everywhere. It can work in the FemPop, like in the InfraPop. We just, you know, Shockwave just came to the market with now the new sizes for the infra popliteal vessels, 2.5, 3, and 4 millimeter, and also works with the ILEX, and it works essentially with the same principle. So the balloon needs to touch the vessel and then needs to work against the calcium. It's very important, and it will be stressed later how the balloon needs to be inflated. And you know, finally, after all this talk, we're going to present the data also of Professor Taper will present the data of the Disrupt PAD 3 randomized control trial. And essentially, enrollment is completed. And the study design, of course, as we said, is randomized control trial. And there are loads of patients, more than 300, and different sites. So that means that, you know, it's not a technology which is just technically challenging, like only few people can do it. You can do it in your lab as well. And also the regions, you know, are different in the world. So there is US, Europe, and also New Zealand. So it's very, I think we have done a little bit of a presentation, and now I think it's my pleasure to introduce again Professor Taper from Rosenheim, who's going to present us the data of the trial.
Yeah, thank you very much, Lorenzo. May I have my slides, please, that I can start? So it's a great honor for me to present the PAD3 results on behalf of all the study participants, and this study was a very big study which was done in several countries, and first of all in the US, then also in Austria and Germany, and as well as in, yes, the next slide please, as well as in New Zealand. And as you see over here, more than 300 patients were enrolled in that trial, 45 global sites. And if you can go back one slide, you see that a total of 153 patients were enrolled in that both arms. And after this, there was the primary endpoint, which was this endpoint of success. And afterwards, the DCB was used. It is very important, and this is summarized in this slide here, it is very important to point out that the primary endpoint was procedural success. And this was because we re-enrolled only highly calcified lesions in that study. and this is an unmet need. Normally, we don't know how to treat those with high pressure balloons, with stents, whatever. Right now in that study, we compared IVL and PTA, and then the images were analyzed for a core lab. In addition to that, afterwards, a DCB or a stent was placed. Everybody who received DCB, and some patients also stents were necessary. So then there were secondary endpoints at 30 days, major adverse events, CTTLR, ABA, Rutherford category, and Walkman impairment questionnaire. And then after 12 months, primary patency was assessed, but this is not a part of this talk. Next slide, please. So this is a summary of the key clinical inclusion and exclusion criteria. So patients with Rutherford category 2 to 4 were allowed in that study. It had to be a de novo lesion in the SFA and the popliteal artery. Reference vessel was between 4 and 7 millimeters, and the lesion length was up to 18 centimeters, and CTOs were allowed up to 10 centimeters. And very important, only those patients were enrolled in that trial which were normally excluded from a study. So severely calcified arteries, moderately and severely calcified arteries, so calcium on parallel sides of the vessel exceeding more than 50% of the lesion length if the length was greater than 5 centimeters, or if the length of the lesion was less than 5 centimeters, at least 2 centimeters of lesion length. So CLI patients could not be enrolled, and also in-stent restenosis. This was the major exclusion. So what we see here is a summary of the study. So as I already stated, between February 2017 and May 2020, 306 patients were enrolled, same number of patients in IVL and PTA. So primary endpoint was an angiographic endpoint. And for this endpoint and the core lab, 146 patients were available in the IVL group, and in the PTA group, 133 patients. And clinical follow-up at 30 days was available in almost every patient. So this is a summary of the baseline characteristics, and I'd like to draw your attention to the p-values. You see there were not any significant differences here. If you look into the diabetic patient cohort, this is 40 to 50% of diabetics. This is normal in such a study. And if we look into the patients of Rutherford, the Rutherford category, you see that most of the patients were classified Rutherford 3. Next slide, please. And the next slide, we have a summary of the lesion characteristic. And if you highlight, or the next click, you highlight the next things, you see that the lesion length was here around 10 centimeters, which is quite long. Calcified length was even longer, and calcification was moderate and severe. And if you see here, severe was in 80 to 90% of the patients, which is really high. This is the procedural characteristics. What you see over here is that the fluoroscopy time differ significantly with higher time in the IVL group, a little bit longer, but of course this is clear because the balloons had to be inflated, and a lot of pulses had to be administered, and of course this has to be controlled by fluoroscopy. But following IVL, you see that post-dilatation was significantly less, 5.2% versus 70%, significant reduction. Also stent placement was significantly reduced, 4.6% versus 18%. This was also a significant number. Next slide, please. In the next slide, we will see that the diameter stenosis after IVL was less than 30% in 2/3 of the patients, versus it was only 50% in the PTA group. And if we look on the left column, IVL, we see that only 3% of the patients had a stenosis greater than 50% after that treatment only, which is really a success of PTA. Yeah, this shows the complications according dissections both in the PTA group and in the IVL group. And I draw your attention to the severe dissection, which are type C and D dissections. And what you can nicely see is that there was a 77% relative risk reduction with IVL compared to PTA to get a type C or D dissection. Over here we see procedural success, and the procedural success was both site-reported and as well it was core-lab adjudicated, and both have shown a significant better result. In IVL, we see 90% versus 64.5% in PTA. Next slide, please. So this was also a success. And final angiographic and clinical outcome has shown not any significant differences here, because also in Rutherford category on the right hand side, this was not after primary treatment only, but this was after DCB treatment, and then in some patients in PTA group, especially stent administration. Next slide, please. Yeah, here we have the safety endpoints, and what we can see is that IVL was safe. We didn't see any distal immunizations. We didn't see any major amputations, emergency risk revascularization, no perforation, but we had a CDTLR in both groups, one patient, which at the end made 0.7%. Yeah, this is a summary, a comparison actually between this study, the PAD3 study, with the observational study, which is a much bigger study. And this has been published, as you see down here in the slide, by Adams recently. This is a much bigger cohort, of course, an all-comer study, not with a follow-up. But what we can nicely see here is that the result post-IVL really is something which is comparable to the result of PAD3 and the randomized trial. And of course, after IVL was done, some patients received DCBs or something else, so the rest stenosis even decreased, which is the green column. So in conclusion, we can say that Disrupt PAD randomized controlled trial provides the largest level 1 evidence for the treatment of heavily calcified fem-pop arteries in a cohort of often excluded patients. Then IVL was superior to PTA in acute procedural success and demonstrated atraumatic treatment with a reduction in percent of diameter stenosis prior to DCB or stent placement, low minimum inflation pressure, reduction of frequency and severity of dissections, and lower post-dilatation and stent implantation rate. And if we can follow here, randomized controlled outcomes are similar to PAD3 registry data in multiple vessel beds, highlighting the consistency of IVL treatment and complex anatomy. And the secondary endpoint of primary patency at 12 months will be analyzed following appropriate follow-up for all enrolled patients. So that's the study.
Thank you, Professor Tepe, for your very interesting presentation on the data. And I don't know if then we're gonna comment even more in details this kind of very impressive data for this very impressive study. So essentially, now I would like to close of course the first poll. Then I would like to go through the results. The first poll was about the use of intravascular lithotripsy in your practice. So essentially, it's 52%, 53 almost percent of the people who say that they use in intravascular lithotripsy, and 47 that they don't. So it's a good half and half, and I think that some people are interested in knowing more about the data and more about the technology, and half of the people maybe are very looking forward to start using it. So let's go with the second then question of the first poll, which is like, if you don't use it, why you don't use it? And I think it's a good question because there are different answers, and also different countries can have different problems. So of course, it looks like the reimbursement is an issue. So 63% of the people said that the cost reimbursement is an issue. The lack of data is 0%. So I mean, like this is very nice, because I mean, like, it looks like people read about this randomized control trial. Skepticism of IVL technology is 25%, and this remains the people who need to be convinced by us that intravascular lithotripsy is safe and effective, and not enough knowledge is 12%. And we're going to try today to address this problem. So my next question is for Professor Tepe. Would you like to share some cases that you have, so at least we can commend them after all this data?
We have prepared 2 cases actually, which were treated within that trial. And if we can see those cases, these cases are SFA cases with a total occlusion. You see this here on the left-hand side, 2 cases, not very long occlusion, but calcified occlusion. And first of all, it's very often an issue to cross the lesion, to re-enter if it's calcified, and then to treat those lesions. And I think it's very difficult to really predict how those lesions behave in the days of PTA only and vessel prep. So the question really is for everybody: how would you proceed? How would you deal with those kind of cases, case 1 and 2? Total calcified, not very long.
So it's very nice. So we're going to launch the second poll then. So as Professor Tepe said, would we use for a vessel preparation strategy in these 2 cases? Answer A is SPOBA, so simple PTA. Answer B, atherectomy, any kind of atherectomy device. Answer 3 is IVL, and answer D, other. So any other thing that it comes to your mind. So in the meantime that you are voting, Professor Tepe, please show us the results of your cases, please.
Yeah, if you can have the case again. So first of all, the people have to vote, of course. Otherwise, they see how we performed in those cases.
Sure, yeah, they will be biased. Yeah, okay, so biased. Yeah, but it's nice. Like 2 lesions are quite similar.
Starting with case 1, and if we have the next slide here of case 1. So that's something which we always do. We just cross the lesion. This case was a case out of that trial. So it was randomized to PTA treatment, and as you see in the 3rd slide, it's not looking. It is antegrade flow, but it's not looking nice. And if we would leave that lesion like it is here, of course, a restenosis or even early re-occlusion would occur. So in that case, a standard superstent was applied. So this was a good result with superstent, but with a superstent. So at least with this short but calcified lesion, we did not succeed to proceed only with a balloon and not using a stent. So this was case number 1, and if we could have case number 2. Case number 2 was a lesion which was similar, I would say, a little bit longer, but also calcified here. And after the IVL treatment, you nicely see that the vessel opened much better than in the example before. It looked very nice. So there's not a significant restenosis here, and as all patients received a DCB afterwards, the final result is after DCB on the right-hand side. Looks even a little bit better, but over here, at least according to the restenosis, I think IVL did very good, and we didn't need a stent here. And this is just an example out of the study for a lot of other patients, and also for an example for daily practice, that IVL does really good and gives astonishing results, and no additional treatment, no stent is needed here.
Gunnar, may I ask you a short question regarding the images shown here? regarding the IVL treatment. It's 2 balloon inflations. Was there a third balloon inflation? Because here in this example, there's no overlap of the balloons. So
there was this was taken from the study that we didn't take all the images. There was a third balloon used in between. So that was out of the study, not at our side, actually, is from another side, but all balloons had to be stored and for the collab analysis. And this is something what we do have to do is we have to overlap the balloons, and also if we inflate the balloons and use the balloons and do the pulses, we very often do the procedure not only once but do it a second time or something like that.
Very nice. And thank you, Professor Tepe, for having showed the 2 cases, as you said, from your daily practice. It's nice to show that, randomized controlled trial are not just patients who are coming out from our daily practice, but this is our daily practice. And this is, I think, is the added value for this randomized controlled trial, including this kind of very difficult patients. I want to see now the results of the poll, which it could be nice to see what people would have done. So I will close the poll and I will try to read the results. There were POBA, atherectomy, IVL, or other. So let's see what comes out from the audience. Hopefully, they didn't get tricked by your presentation, Professor Tepe. So essentially, it's 40-40 POBA with atherectomy. So people divide in a very standard approach with POBA and atherectomy, and we remember also the atherectomy, for example, needs a filter. So atherectomy plus filter, which increases the cost and increases also the complexity sometimes of this procedure, and where only 20% would have gone for IVL. And IVL, as we mentioned before, doesn't require any filter because there's no distal embolization recorded. No one would do anything else. So it's nice to see, if maybe the poll, the people would change the idea after the finishing this webinar. And let me ask a question then to Dr. Schwintz. So how do you think that patients scored in this kind of randomized control trial compared to the other trials? And I'm asking also, as investigators, do you think that it's important to involve this very complex patient in such a study?
Well, thank you for your question. Well, I remember asking you this question that Gunnar and I met in 2016 in Washington at TCT, and my task was future needs in endovascular therapy. And if you look at the early DCB trials, for example, Impact SFA, and compare it to PAD3, PAD3 treated patients that were excluded from all the DCB trials. So severe calcification was an exclusion criteria in almost every DCB trial I recall. And same is also with adjunctive devices. And so what makes PAD3 so unique is that we now look at this part of patients that have been left behind in the early DCB technology. And for example, what also concerning complications like dissection, if you recall it, the randomization in the early DCB trials took place after successful predilation. So if you had a grade C dissection after predilation, patient was excluded from the trial. So what we know is that we deal with very selected patients if we look at the data. And often when I discuss about vessel preparation, it is like, wow, why should I use this technology with DCB? I have 80% patency, and we have to recall that this 80% patency is in patients with normal renal function, no calcium, no dissection in the predilation, And in the real world scenario, this is just not going to happen. And if you see that if you compare, for example, registries like Impact Global and Impact SFA trial, you see once you treat a real world scenario, your stent rate goes up from the low 1-digit numbers to 40%.
Yeah, it's very important what you said, because one of the main important topics is the bailout standing, which I think it's something that has been touched, and it's impressive data from this randomized control trial which are presenting today. And I think this is the main one of the main take-home messages. If you lower the bailout standing in such calcified and difficult lesions, I think you have done a good job.
Yeah, that's number one. And number two is other technologies are more hazardous in unexperienced hands. For example, Reality, I don't have the slide now, but I can tell you, had a distal embolization rate of about 12% and a perforation rate of about 3%, whereas if you recall Gunnar's presentation on the shockwave data, there was 0 and 0 concerning these both modalities. We have few data for this very difficult patient subset, and the data that we see now concerning safety, the viewpoint is very convincing.
Great. I think it is very well said, very convincing. And now I have a question for Professor Zeller, because he's an expert about evidence. So I want to ask him, what about this kind of level 1 evidence? So what, distinguish, another registry with this study, which is a randomized control trial in such a patients? Do you want to tell us more about the added value of this trial?
Yeah, well, definitely. I believe what is missing for all other kind of vessel preparation devices so far are really controlled studies. That mean that a control cohort, which is the standard of care, which is usually balloon angioplasty, is missing for these vessel preparation systems. And IVL, it's not for free, so it's additional costs, and it's therefore important to study this new technology against plain balloon angioplasty as a standard of care vessel preparation procedure. And this makes it so important. And we learned that IVL is not simply based on a longer inflation time more effective than PTA, because the dilatation protocols had been very similar. It's really the effect of lithotripsy that resulted in these superior short-term and acute outcomes, meaning reduced dissection rate, reduced stent rate, reduced post-dilatation rate. So therefore, it's very important before you add additional money for an vessel preparation procedure, you need to know whether this is worthwhile to do so, and that's the main value of this randomized study, representing a level 1 study.
Great. I think it's very important. Also, I think I have to congratulate with Shockwave, because it's a sign of very much confidence in their technology if they want to embark themselves in a randomized control trial. So well done. And, we're waiting, of course, also the long-term results. But for now, I think it's a brave move, which is paying the bravery. So, I want also to ask one question, if I can, to Professor Tepe. So, I was also thinking about, usually, the primary endpoint is a bit of a strange, so it's a primary endpoint following vessel preparation to measure procedural success. So can you just give us an overview of the importance of this kind of very strange primary endpoint?
Yeah, for me, it's not strange. Thank you very much for the question. It's something which really is focusing the lesion and the severe calcium which we have over here. And the problem with severe calcium is very often that, as we've seen also in the trial, is that with balloon angioplasty, we cannot successfully treat or pre-treat those lesions. And the primary endpoint is really focusing on the mechanism of the catheter of the IVL, and really looks if this treatment modality is better than standard therapy. And therefore, it's very important to look at the primary endpoint. And I think in this study, the shockwave catheter has a chance to win twice. The first one is to win at the very beginning, is to win and showing the efficacy treating calcium, so acute result, and the second one would be later on, and this is a secondary endpoint to see if this vessel prep in the early stage also might translate in a different patency rate. So both groups were treated the same way with DCBs afterwards. So we have two chances here to win, but the first thing is very important, and this is something which we see on the table in the cath lab, is that calcium issue is an issue here, and therefore it's very important to address this with a primary endpoint.
Very good. I think, yeah, that's very important to know about these things. Yes, and I want to ask you then if I can, to Dr. Schwind. So, I mean, we have seen the results of the poll. So, I mean, 60% of the people would have done some vessel preparation. 40% would have used POBA only. So I would like to know from you, also from the German experts, what's your point about the vessel preparation? Is it important? Is it useless? Just give us your opinion on what you find in your clinical practice and what you can find in literature, please.
So what we know is that there's, three mechanisms that our endovascular procedures fail after successful crossing and treatment. That one is flow limiting dissection. The second is elastic recoil. And the third is myointimal hyperplasia. And we have different tools to address these three failure modes. To prevent dissection, good technique is important, not to go too high pressure. Prolonged PTA gives good results. There's a nice article from Sorger that compared 30-second PTA versus 3-minute PTA, which gave in a 20-patient each arm cohort significant results, preferring the longer PTA. For elastic recoil, we had stents in the last 2 decades. But stents themselves will cause intimal hyperplasia in the long run. That's a problem. And so in these very calcified lesions, you need to do something to have a good acute outcome. Even if you go for ballooning with high pressure balloons, you very often end up with the stent, and even that stent cannot open adequately if you use a standard 90-node stent. And the worst thing that you can do for your patient is that you try to put a supera in that does not open completely. And so what does IVL do in vessel preparation? We crack the calcium, we generate a lot of fractures inside of the plaque, and that gives the vessel back plasticity. And I think that is of fundamental importance.
So I would like, to make even things a bit more dynamic, I would like Professor Zeller, I think you should have a case, and I would like you to present it, so at least we can discuss about the findings.
Well, definitely. This is just a case from last week. It's an 80-year-old female patient who represented with rest pain at night on her right leg, mainly on the forefoot level. What is missing here are the outflow images. So there was also 3-vessel outflow disease at the calf level. But what was essential for this webinar was this very diffuse, severely eccentrically calcified femoropopliteal disease, which is shown over here in those pre-interventional images. So a couple of subtotal occlusions caused by really severe intraluminal calcification. And so the lesion ended more or less at the upper level of the patella. So if you can have the next slide, we can see this is only one still image of the IVL treatment I did perform. So I treated the entire length of the SFA, starting at the adductor channel down to the patella level. with intravascular lithotripsy using a 5 millimeter balloon, which was probably a little bit conservative regarding sizing. We could have even used a 5.5 millimeter balloon. And this was then followed by post-dilatation with overall 3 drug-coated balloons, 5 millimeter diameter distal and 6 millimeter more proximal. And the final outcome over here can be seen then in the following images, which is shown over here. So we have now a good luminal gain, and most important is that there is no dissection, and everybody who is doing such kind of lesions or performing such interventions in such kind of lesions knows that if you simply perform plain balloon angioplasty, even followed by long drug-coated balloon inflation, you will see some dissections, and they may also result then in stent implantation. So at the level of the adductor channel, there is a mild residual stenosis, which could have been treated with a bigger balloon potentially, but the remaining lesions look very nice, in my opinion. I don't know,
yes.
what's your...
Definitely, I think it looks very nice. And I would like you to ask a little question, very specific. So can you talk about the sizing of the balloon? Because you mentioned that in your presentation. So is the balloon needs to be sized 1-to-1, even a bit more? Can you tell us your experience?
Well, in general, and that's true for every kind of balloon-based procedure. What we learned in the last couple of years is basically that you should not be too conservative in balloon sizing. That's true for IVL, that's true for drug-coated balloon angioplasty. Undersizing does result in recoil. It does even result in more frequent dissections. So the recommendation in general, in particular for IVL, is that you slightly can oversize the balloon according to the reference vessel diameter. So if you have a 5.0 millimeter reference vessel diameter, you should use a 5.5 millimeter IVL balloon. That's what may have been used here, in a better strategy as I did with 5 millimeter. In my initial view, I thought, well, an 80-year-old male patient, very fragile arteries. I'm a little bit reluctant regarding a bigger size, but 5.5 would have been the appropriate size here.
It's very important. Yes, this is very important because people also need to understand that a balloon works only when it touches the calcium. So if it doesn't touch the calcium, it doesn't work. So it's not some remote signal which works from far away. So it needs to touch. And it's very important for any vessel. It could be the iliacs, could be the BTK, could be the FEMPOP. And also, you know, the other question I have for you now regarding also the data of the study. And I think it's a hot topic. Why do you think the IVL was randomized against normal PTA when instead atherectomy is frequently used in calcified lesions? And also, I will ask you how then the study results compared to other technologies for vessel preparation studies.
Well, as already mentioned, basically we have not yet any study data comparing any kind of vessel preparation device against plain balloon angioplasty prior to DCB angioplasty. The only exception is the definitive AR study. However, this study was not adequately sized regarding sample size, so it was underpowered, and we only found trends for a better outcome of atherectomy in less severely calcified lesions as enrolled into the PAD3 study. So basically, if we compare now the performance of other vessel preparation devices like directional atherectomy or like orbital atherectomy, as shown in this slide, even if we cannot compare those outcomes by 1-to-1, because these are not direct comparisons, it's simply comparing published literature. However, if we look on dissections of grade 3 or even more severe, we can see that IVL is not at least inferior to directional atherectomy or orbital atherectomy. Then if we look on the stent rate, again, it does not seem that IVL without removing plaque material is inferior in performance in avoiding bailout stenting. And regarding embolism, we found no distal embolization. However, with, of course, any kind of atherectomy system, there's a given risk of distal embolization, which we didn't find with IVL, and the same holds true for perforations. So overall, even if this is not a one-to-one or direct comparison against atherectomy, IVL performs very well as compared to what is published for calcified lesions regarding the use of atherectomy. So as mentioned, POBA is still the gold standard. It has to be shown that vessel preparation is superior. And now we have the first study which clearly shows, at least based on acute outcomes, IVL is the better vessel preparation system than POBA in calcified lesions.
No, it's very important because, as you said, the first randomized control trial in these kind of patients. And now I have just this free, before going for maybe on another case, I want to ask very few questions but very quick answer, please. So the first one is the one that is on the screen that you can all see, and I want to ask this to Professor Tepe. So with excellent procedural result and improved vessel preparation, should we expect this to carry through the 12-month outcomes? So very quick answer.
I hope so.
Okay, that's nice, and I think it's the bailout stenting very low result. I think it will be very in favor of the patency of the patients treated with IVL. Then the second question is for Dr. Schwind, and it's coming from someone of the audience, because there are loads of questions, but also there's not enough time sometimes. And he asking, like, how do you measure the percentage of calcium in the vessels? We know there are different classifications. Can you tell us what you do in your clinical practice, Dr. Schwind?
There's different methods you can use. There is a classification by Scheinert that says, single spots of calcium in the wall is mild. Areas with bilateral calcium is moderate, and complete lesion with bilateral calcium is severe. But this is better a question to Gunnar Tepe. What definition was used in PAD 3?
The PAC score, I think.
PAC score, yeah.
Perfect, and it's nice also because sometimes there's not very much agreement sometimes on the classification score. So yeah, it's nice. And I also have other few questions. For example, what about small vessels? So does someone of you have experience with below the knee vessels? Do you use the new balloons, the 3 millimeter, the 2.5?
So we have initial experience now with the 4 French, with the 5 French device for BTK. It works. However, the experience is limited till now, and we always have to think about that. When do we treat BTK disease and critical ischemia? And using IVL for the BTK segment with a 4 centimeter long balloon, you have to do a lot of cycles doing that, but definitely works there. The question should be, not so much if we can avoid the stents, but probably more like in coronaries, can it help to open up stents in the trifurcation area properly?
Which is a very nice point. So yeah, and then also, Professor Zeller, does IVL work in the subintimal space? This is something that people usually ask. What's your experience?
PAD 2 has shown that IVL is equally effective in concentric and eccentric lesions looking on the acute luminal gain. So what are we facing if we are going subintimal? We have a eccentric distribution of calcium if we are in the subintimal channel. And so far there is no really controlled data available with regard to the use in the subintimal space, but based on the experience we made in the PET-2 study, it seems that it is effective also in the subintimal space, but you have to consider if you are dealing with a 1 centimeter thick calcium layer, what we sometimes are facing if we are treating really severely calcified CTOs crossing subintimal. There is even a limitation for IVL application. So that means if we have a thin layer of calcium, it will be definitely effective. But if the calcium is too big, there is probably even no way for IVL in order to reduce the calcium resistance. But as mentioned, for that application, to the best of my knowledge, there is no data published or presented yet.
No, it's very nice also because, I mean, when we are talking about subintimal space, this already cuts off all the atherectomy devices. So it could be a good space for IVL where no one else can be used, especially, I mean, if you want to keep into the IFU. And also, you know, it's very interesting because you showed also the case that you mentioned before, where you said very diseased BTK vessels has run off. So these are the typical vessels where you don't want to embolize. And just to answer to a question that came out from the audience, you know, of course, IVL has shown to be safer, as also Professor Zeller said before, than atherectomy, because the amount of distal embolization is 0 in the trial and close to 0 also in clinical practice. So I think it's very safe. So I would like now, there are a few minutes now, I will ask Arne to show us a case of common femoral artery, because I think it's important to, the common femoral artery is a territory which is, you know, very delicate. And so if you can show us very quickly your case and show us what IVL did, and then we can wrap up with the last questions.
Perfect. So this is a case of a bit problematic patient, 61-year-old male academic with severe claudication and bilateral common femoral artery CTO. However, he was very busy in his job and did not want open surgery, and he asked about 5 clinics in Berlin for EVT, but because of the severe calcium, he was refused and made his trip to Münster. And I just said, okay, we can try. We have new technology available. I can promise nothing. So what we did is first we treated the right side. We had to do an antegrade retrograde approach because we went subintimal right away. And then we tried atherectomy with very poor lumen gain in the first place. And then we treated with 7 millimeter shockwave balloon. And then with an 8 millimeter DCB, making room for a supera. So I go back one time. Here you see the lumen gain with IVL. And here you see the final result where IVL was able to open this stent completely. So because he had bilateral disease, he came back some weeks later. We did an ultrasound guided puncture above the first lesion on the right side and did the absolute same treatment on the left side. And achieving this result. And, you know, I'm a surgeon. But hemodynamically, this was an absolute valuable procedure. You know, he had the foot pulses palpable. He had 0 symptoms after it. He had an ABI bigger than 1 bilateral. And we even did a 90-degree hip flexion angiography to see if there are any kinks or problems that come with the implant. And we see here a very nice harmonic reconstruction. And what I always think as a surgeon, you know, these therapies are not competitive, they are sequential. So if this stent at any time gets a bigger problem, I can go back surgically or endovascular at any time. So this is something we can discuss. Is there room for this therapy in other vascular beds?
It's a very, very impressive case, especially the comparison between the two technologies, where the little drill, the oak one, tried to scrape this kind of very calcified surface. So essentially, what's nice also, the two devices are working in a very different way. So one is just try to scratch this stone, and the other one is breaking the stone, and so then helping with balloon after you can get these results. Very impressive, especially one side you were able to expand the stent perfectly. The superior, on the other one, there was not even need of stent. So, and then I will ask you then also, based also on this experience, how does results translate into real world? Well, we've seen on the first poll that sometimes costs are an issue, and to introduce new technologies, it's difficult because procurement issues. You need to demonstrate that your technology does better than the other one. How would you comment? Arne, is for you.
Okay.
Yeah.
So what I like about the technology is it's very easy to use. So what I see in our department, there's a very few fierce atherectomy guys like myself, and a lot of people who went with stenting and POBA for a long time, and their threshold to use and appreciate this technology is much lower with this device. And I think this is mainly because of the safety profile. Whoever has done his first 20 atherectomies has done his first perforation. This is just how it is. And this is an experience where the pressure of the patient drops and your own pressure rises. And
to balance.
And I think, with IVL, you can feel on the safe side. I think if we do enough cases, we will actually see an embolization in a mixed plug with IVL. I know one colleague who has seen one case, but this is after thousands of applications now. And so concerning with the other methods of vessel preparation, it's safe and effective. What's better in which lesion has still to be decided in the future.
That's very nice answer. So, and I would like now to launch the last poll, because the time is running very fast. So Paul, if you can put the last poll, just to measure the success of this webinar, which is going to the end. So have we been successful in presenting the value of intravascular lithotripsy during this roundtable discussion? And then we would like to hear from you, and especially the people who are not using it before, if they think about considering using it. And I have last three things. I will ask, of course, Professor Tippe to tell us a little bit, wrap up this webinar, and you summarize the key takeaway of the study results.
Yeah, thank you very much, Lorenzo. Key takeaways are very easy. So I think the study has shown that IVL achieved superior vessel preparation, and you just have to remember the figure around 70 to 80%. It's all 70 to 80% better compared to PTA. So we had 75% less stent placement. We had 69% reduction of need of post-dilatation, and 77% reduction of type C or greater dissection. So according vessel prep, this was superior and easy. And as we already discussed, no major drawbacks, no side effects, no dislocation, no preparation.
Very nice. And I want to ask Professor Zeller, so in your practice, so just to finalize, why do you choose to use IVL?
Well, basically it's simple. It's simple to be applied, and you already mentioned I'm doing atherectomy since more than 20 years now, and even if I still use atherectomy, so for me it's a complementary device in some cases. It's easier regarding handling to perform IVL as compared to atherectomy. The setup of the technology is quicker. And therefore, I'm frequently using lithotripsy in particular in longer diffuse lesions, where I'm still using atherectomy, in particular directional atherectomy in more focal lesions.
That's a very nice question. Yes, and also, you know, we all know that Shockwave is developing longer balloons. I mean, it's a technology which is of course transforming our world. It's also evolving with us. So I would like to close the poll. Then you know, about how good when we give us votes from 0 to 10. Let's see how people were happy about our discussion. So Paul put the poll results. Okay, that's very nice, very encouraging. So 93.3% of the people think that this the roundtable was successful in demonstrating the results and the value of IVL, and only 7% are not. But we hope that maybe with the 12 months data, which will come out, of course, very soon, we'll be able to, make everyone happy. So, I mean, I think we passed an excellent hour together, and I would like to, of course, to thank all the speakers, Professor Zeller, Dr. Schwint, and Professor Tipi. And we think that, we are all men of this world. We are also looking forward to know more about technology. We like to investigate. And I think if we stay together in this with some solid data like randomized controlled trials, we're going to go far. So thanks again to the panelists, and thanks also to all the people who listened to us, who were so patient to listen to us, and see you maybe next time in 6 months for the new data. Thank you a lot, and good evening to everyone.
Thank you.
Thank you, Lorenzo.
Good evening.
Bye-bye.